morning, Dr. Patino here at the Cosmetic Surgical Center of Costa Rica. This is my career power assisted liposuction. And what we're doing is we're doing this very gently, right? And we waited for at least an hour, right? So you can see whenever the fat starts coming out, you can see that it's going to be completely bloodless. How do I know that? Because we do that consistently, right? And that's very important. It's a special, different technique that has many advantages to the patient and many advantages to the surgeon as well. The advantages to the patient: much less risk of bleeding, anemia, blood transfusions, evacuation of hematoma, hospitalization, and when you transfer these to the buttocks, much less risk of blowout fractures, oil cysts, painful nodules, and even with liposuction, fibrosis and fibrotic bands. All of that is the result of the body rejecting that blood that's outside the blood vessels where it's supposed to be, and it's irritating to the tissues, right? And how do we obtain this beautiful bloodless aspirate, right? Well, the way to do it, it starts with the patient. Patient selection, right? If the patient has a blood dyscrasia or bleeding disorder, we're not going to operate on it. If the patient has a blood clotting disorder or tendency to blood clots or any disease that predisposes to blood clots or has a personal or family history of blood clots, we're not going to operate on it. Because those patients would need blood thinners, and if you give blood thinners, there is no way that you can get this output. No way. And some doctors routinely give blood thinners to the patients so that they don't get a blood clot. That's acceptable practice, right? But we don't do that. We select our patients so we don't have to do that. And I believe that the best way to prevent a blood clot is not enoxaparin, it's not heparin, it's not aspirin like medications. Is ambulating, walking. So our patients walk 1 mile the first day, 2 miles the second day, 3 miles the third day, preventing thromboembolism, preventing a blood clot. That's the best way to prevent that and to prevent death. And thanks to God, we never had anybody die, and we want to keep it that way. But even if you ask a child, do you want your procedure done with bleeding or no bleeding? You see a child sees blood and they get scared. They start crying, right? And they know that it's not a good thing, right? But even surgeons, we're brainwashed in medical school and through training that bleeding is good, that if you bleed, the tissues are well perfused, and I believe that that is just rationalization for the surgeon when there is bleeding, because it is stressful to the surgeon. When there is blood loss, it's always stressful, because we know that when there is blood loss, the patient can die. We know that the patient have severe anemia, and when you do blood transfusions, there is risk, right? And so we surgeons heard many times, and we all believe that, the surgeon that does the most surgery gets the most complications. I believe is the surgeon that does all the bloody surgeons, that gets all the blood. So in order to obtain this bloodless aspirate, we instruct the patient not to take any aspirin-like medications, no ibuprofen, no herbs, no vitamins of any kind, at least 2 weeks before and 2 weeks after the procedure. And we, the surgeons, don't give any aspirin-like medications or enoxaparin or heparin-like medications, because that's going to make you bleed. And we don't give ibuprofen or any other medications that can cause bleeding even after the procedure, right? And we use the tumescent anesthesia that has epinephrine, and we do plenty of tumescent anesthesia. If you just use 1 liter from the front and 1 from the back and you start right away, you cannot obtain this aspirate. There is going to be bleeding. Yeah, you have to tumesce in all areas, tumesce properly, and wait. We wait a good hour before we start the procedure, right? For the epinephrine to clamp down the blood vessels. We know that the epinephrine takes at least 15 minutes, but the longer you wait and the more of the tumescent anesthesia you put, the more vasoconstriction you're gonna have. And we notice that we start on the first area that we tumescent, and you would think that the last area is gonna have more bleeding or whatever, and it is the opposite. Our last area is probably even better than what you see right now, and we'll show it to you. And so it is just a special technique, and of course also the speed of the surgeon. So notice how my strokes are very calculated, very slow, and I use both hands 50% of the time. You'll see me use my non-dominant hand. Right now this is my dominant hand, right? So I'm going to use my non-dominant hand later on, and then you'll see the big difference, right? So this decreases occupational injury for the surgeon in the form of tendinitis, but it also prevents, and even more importantly, the patient from having intra-abdominal or intrathoracic injury, something that has never happened to us. I believe that happens to a very fatigued surgeon, maybe on a Friday night after doing many cases, going at full speed and just loses control and goes into an unintended area. And that's very much similar to driving at night after. So I compare this to driving. You know, if you drive and you're tired, you haven't slept, and especially you're driving at night and you're going at full speed, you're gonna go into an unintended area and crash, right? I think the same thing happens to a surgeon that's fatigued from, you know, operating all day and perhaps all week, in many cases a day. You know, I know doctors that do 13 of these cases in one day, you know? And I have the highest respect for them and all. But I think at the end of the day, the surgeon is tired, you know, and they just want to be done with the case, I would imagine, and go at full speed, and then that's when accidents happen, you know, similar to driving a car. In addition, you know, we go slow, right? So my strokes are slow, very well calculated, and we only operate on 1 or 2 patients a day at the most, right? So that's how you prevent these problems. Thank you. Yeah, so, you know, that's important. You know, I think that, and I have the highest respect for my friends who do many cases like that, and of course they have a big team of people assisting them and everything, because obviously a surgeon by himself cannot do all those cases, right? So they have to have somebody else doing the liposuction, and usually they just do the fat transfer to the buttocks or something like that. But even for the fat transfer, for example, if, you know, we lower our speed of aspiration, we lower the power on purpose, so that we don't damage. And when you put oil into the buttocks, right, the body rejects it, and the body forms a callus, pushes it out, and you have an oil cyst, right? Or you get blood or dead fat cells, and the body rejects it, makes a capsule around it, pushes it out, right? And you end up with a blowout fracture, which is like a tennis ball or even a bigger ball sticking out of the buttocks, right? It's like a body foreign reaction. The body just rejects the blood and rejects the oil that doesn't supposed to be there. It only makes sense, right? And pushes it out towards the surface. Thank you. So I'm using my non-dominant hand, so much less risk of intrathoracic or intra-abdominal injury to the patient, which we never have. And that's because the strokes are very calculated, very slow. And I do this with both hands, right? So that's very important. Thank you. All right, so notice how we're down to 0.5 centimeters, right, Gabby?
Right.
And notice it's still, look at the beautiful aspirate that we're getting. Notice how I'm pretty much down to the end of this procedure, right? And I already did the semilunar lines on either side. Those are the lines around the six-pack area. We're giving her a high definition liposculpture, feminine look, right? And we already did the linea alba. We're gonna show you how it looks, but what I want you to see now is how that output is still beautiful yellow fat right there. Thank you. So good for the patient, less risk of intra-abdominal or intrathoracic injury because of the very well calculated and slow motions. Good for the surgeon because it prevents the surgeon from big effort and sweating and repetitive motion with both hands. Hasn't been treated in any way whatsoever and is going in. I'm looking at the fat graft that's going in. I'm looking at the patient and I'm also looking at the house. So look at the beautiful fat graft that's going in, completely bloodless and oilless. This is incredible. This is the fat that we took out and is going in the same way. It has not been treated in any way. So I'm looking at what's going in, I'm looking at the patient, and I'm looking at the ultrasound. We have multiple workshops throughout the United States and abroad teaching doctors how to do BBL safely under ultrasound guidance. Thank you.
All right, we're doing ultrasound guided gluteal fat transfer. This is the patient's skin right here. This is the superficial gluteal fascia, which you can see there's a break in it right here. So we have one line there and one line there, but this is one piece, the superficial gluteal fascia. This is Dr. Patino's cannula. He's going to wiggle it for us. So he sees it wiggling. And then actually right here, we have the deep gluteal fascia, and you can see the striated muscle. So she has a really tiny little space in the deep subcutaneous space. We see Dr. Patino's cannula, the point of it right here. So he's going to withdraw it a little bit more, and we're going to see a bolus of fat entering the space right now. And so you see this gray on the ultrasound is the bolus of fat entering the space, and now we see that the deep gluteal fascia is actually being pushed down. So where it was at maybe like 2 centimeters, now it's getting pushed down a little bit. We'll see over the course of the case that it's going to kind of get pushed down as fat occupies the space. Alright, so we have a beautiful view here. This is the striated muscle, and you can see that right about at 2 centimeters, that's the deep gluteal fascia. This is where we don't want to be putting any fat. Above it, we have Dr. Patino's cannula, and above that, we have this superficial gluteal fascia. So between the superficial gluteal fascia and the deep gluteal fascia, that's the deep subcutaneous space in which doctor wants to be putting fat. Above here, we have the patient's skin.
And here's the bolus. You see that gray
So
cloud?
now we're seeing a gray cloud as doctor described. That's fat entering the deep subcutaneous space. And what we're going to notice is that basically the deep gluteal fascia is going to get pushed down as fat enters this deep gluteal space.
Thank you.